Okay, so I hope you haven't been model of cared out. I mean, we've had Deb this morning, we've had Martin, etc., but it seemed to be quite a buzzword. So, but certainly the issue of model of care issue is one that's been grappled with here in Australia, within the public dental arena, and certainly indeed across the whole globe, and it's becoming extremely critical at present. I think it's been raised a number of times with the funding that's flowing through from following the NPA, the signing of the NPA across Australia and here in Victoria. Certainly the models of care are very commonplace within the medical arena. I think that having worked in New South Wales and Tasmania and now here, I think we're all on the same page, and I think each has their own challenges. I mean, New South Wales got their challenge, Tasmania has their challenges, Victoria has their challenges, but also the benefits of actually introducing different models of care. I mean, the structures are quite different here in Victoria in the public dental arena to Tasmania, and we have advantages in Tasmania to introduce models of care because we're a statewide service and we're all under the one umbrella. But we're within the public health, we're in the department. Whereas here you've got different agencies, and we heard from Martin earlier today, which introduced a very interesting model of care at North Richmond. So that's an advantage of having the structure here in Victoria. Okay, move on. So just an overview of my presentation, looking at the need for the obligation for change for a model of care, the evidence behind it, underpinning it all, the challenges and hurdles that you may encounter along the way, and there's always going to be a lot of those, but they're not insurmountable, and they vary from area to area and facility to facility. And then the last of all, the adaptation of models of care, the principles, to specific service delivery units or facilities or agencies. And we're looking at model of care principles, looking with, as we've talked about, a population health outcomes, and certainly with Andrea and her team this morning, I think we've got to look at a model of care. If we're looking at a publicly funded, taxpayer-funded service, we've got to look at population outcomes specifically to make that investment of public dollars realise the value. Okay, the key questions, and certainly these were raised this morning, I think with Martin as well, when looking at developing a model of care in your agency or your area or your unit. I mean, it doesn't matter whether it's an agency or a unit or the hospital or a unit within the hospital. The key questions are these: what services are you going to provide? Why are we going to provide these services in a specific way? How do you provide them currently? And what are your future options to provide those services? Who are you going to provide them to? Are you going to target certain services to certain groups of people? Are you going to limit, or is it going to be universal? So again, this is all dependent on resources and resources availability, but still the principle of a population health outcome, a population health approach and health outcomes rather than outputs, as Deb talked about this morning, is critical in this. I think the private sector, I mean, Mike Morgan touched on the difference between public and private. I think the public-private and the education sectors, when we're looking at the future and models of care, we're going to have to work together, because we can't just have, you know, a public sector model, private sector model, an educative type undergraduate, you know, an education model. We've got to work together, and there are ways of doing that. And I think we need to explore that, and I still think that Australia is too small a country. Dentistry has been siloed. We've got a number of sectors, we've got some good ideas in all the sectors, and I think each of those sectors will need to play a role in future models of care within the public sector dentistry, and certainly that'll be borne out, I think, in the NPA funding this round and also the future rounds. Okay, the need and for the obligation for change. I mean, clearly a primary healthcare team approach is a necessity. It's been successful in managing most systemic diseases across a population with population outcomes. You need a primary healthcare approach, a team approach, and that's the broader team approach. Both the clinical team, non-clinical team, medical team, and allied health team. And as we've talked already today, numerous speakers have talked about, you know, the patient-centered care, the patient focus, not the tooth-teeth focus, leading to a population outcome. Certainly there's a need to actually move from that procedural based, that surgical dental model to the patient focused, patient centered treatment plan, care plan, leading to a population outcome, because, you know, as we all know, the surgical approach doesn't produce any improvements in an oral health. You don't get an improvement in oral health because of drilling and filling. It's never the improvements that have occurred are from the population approach, and certainly one of the clear ones was the fluoridation of water and the introduction of fluoridated toothpaste. We cannot continue to deliver more of the same. The private sector model, I mean, clearly the private sector model works. So you've got a dentist with, you know, 2,500, 3,000 patients, and they work and manage that cohort, and as Mike touched on this morning, that model does work, and I see that role, that sector playing a role within future models of care, certainly from a public sector point of view, and developing partnerships, but having them work with us to develop some aspect of the model of care, but not disrupting or interfering with principally that private sector model, because that does play a role with any health system. Certainly, due to workforce to population ratios, as we talked about with, you know, the private sector model, you know, there is no, realistically, if we continue to do more of the same, with the ratios of oral health practitioners, whether it be dentists, oral health therapists, dental hygienists to 100,000 per 100,000 population, that realistically, and doing a surgical approach, you're not going to get a population health outcome or improvement in oral health if you continue that sort of, as I always call it, the bum on seat type model, you know, getting them to having to come into your facility, do treatment and go out. That's not going to produce any outcome. It's part of the process, it's part of the model, but certainly won't produce the outcome that you want to achieve with the expenditure of the public dollar. So clearly, without all sectors working together, the only thing that any public dental service can hope to achieve, working the way we are at the moment, the way all jurisdictions are working, is really just to only achieve, and it was mentioned, in public systems at the moment, we only do 15% of the dentistry, 85% is in the public sector, in the private sector. So we've got to work with them in some model in the future, and we've certainly got to explore this, certainly with these dollars flowing from the Commonwealth Government. So the only thing we can hope to achieve if we don't change is just from a population disease control or improvement of a disease outcome perspective, is a disease minimisation with improved quality of life outcomes. So you can't really expect much more than that, and I think that's all most jurisdictions are doing at this point in time. We've got relief of pain, we've got emergency, we've got a whole lot of programs happening with a surgical approach happening at the moment, the models that are actually happening within a lot of the organisations. But the move towards, say, for the North Richmond model, that's sort of moving down a pathway that couldn't be broadened out. That's an 8-chair clinic, but that needs to happen right across Australia if we're going to bear, if it's going to bear fruits from a population perspective. Certainly, any model of care, a model of care with population health outcomes, from my perspective, derives its support from PMPs, the preventive maintenance programs. So the preventive maintenance programs underpin any model of care from my perspective. I mean, we need to, in managing a chronic disease, anything that we do surgically needs to be preventively maintained, and that maintenance can vary from aggressive to minimalistic, a minimal contact, review and evaluation. A lot of strategies from a point of view of the preventive maintenance programs. But certainly we need to, the preventive maintenance programs need to be one of the key components of any model of care within public sector dentistry for the future. And the increasingly pressured health dollar, it's like a rubber band, it's almost snapping at the moment. I mean, other areas of the health sector always grabbing at the health dollar. It's being pressured. We have been lucky in getting some NPA money coming through, as Deb talked about earlier today. But that, you know, that's just end stage treatment. Ultimately, that's end stage treatment. So I think now the environment's right, the fruit's ripe for picking here. We've got to move to the next stage whereby we capitalise on the NPA funding. It's treatment based, it's end stage treatment, it's funding for item numbers, for interventions, restorations, etc. But we need to realise that by developing models of care to actually capitalise that on. I think that'll be the next step in this whole public sector arena of models of care. Next is the management of the oral environment in harmony with other body systems. I mean, the US Surgeon General back in 2000 said that the mouth was a mirror of the body. So the model of care is playing its part in that statement. Clearly, we need to develop models of care that work in harmony with other body systems, not just independently to the rest of the body. That's both medically and socially. And we heard from Andrea's team this morning the social determinants of health and the downstream, and their downstream work, which we're doing exceptionally well at the moment, but the upstream pressures are preventing the population health outcomes. We just can't get the improvements from what we're doing at the moment. And it's very expensive, and we're just not getting what we should be getting. So now's the time to look at different models to realise the benefit of the funding that's coming through for that downstream type of program. And the NPA is funding really a downstream program. Okay, we also need to reduce the overall inflammatory burden of disease. I mean, dental caries, periodontal disease, increases the circulating inflammatory cytokines. I mean, we've got just normal physiologic stress, we've got smoking, obesity, diabetes. All these create a level of inflammatory burden and burden of disease on individuals and populations. And we just need to play the model of care we need to, which is expensive, the model of care we need to develop needs to reduce that overall inflammatory burden of disease. Requirement to capitalise on resource-intensive oral end-stage treatments, as I've already said. That's the downstream programs we have at the moment. We need to capitalise on that, and that we need to do that via a model of care underpinned by the critical component of preventive maintenance programs. We need to efficiently and effectively utilise our workforce. That's including our university undergraduate workforce and postgraduate workforce, our clinical and non-clinical workforce, and medical as well, and allied health. So it's the primary healthcare, the extended primary healthcare team. And certainly in Tasmania, it was much easier to actually develop models of care along these lines because we had health organisations where oral health was actually part of health organisations and part of all the allied health. So pathways, clinical pathways, models of care that incorporated oral health into general health and allied health was facilitated. Here in Victoria, a little bit harder. So, but that's a challenge. That's a challenge for Victoria, but certainly not insurmountable. And certainly the demand increase. I mean, you know, with the money flowing, with the millions of dollars that are going to be flowing into Victoria over the years to come, demand, the more dentistry we do, the demand just increases. I mean, you look at the Commonwealth Dental Health Program in the 1990s. I mean, that just blew out of the water. I mean, waiting list statistics, when that stopped, the demand had increased, and waiting lists just blew out of the water. So that's the nature of dentistry, because the downstream programs, end-stage treatments, the more you do that without managing that as a chronic disease, just creates more dentistry. The repair, the management, the recurrent disease, the disease process, the chronic disease process has not been managed. So therefore the current, like the NHS, the same thing, you know, pump a whole lot of money into end-stage treatments and it just creates more dentistry. That's the nature of the science behind the caries process. So the concept, I feel in the future that waiting lists, the old model of waiting lists being, well, how many knees and hip replacements, that's the classical, you know, you have a waiting list and you replace a knee or replace a hip, and that's dear to my heart, having my knee operated on a number of times. But so you come off the list. It's been done, and you're off the list, and that's it. The management is really it's not a process. It's a waiting list. You're on it. You're off it. Waiting lists in dentistry, I feel, because it's a chronic disease, your waiting list is as big as your target population. So waiting lists are going to be here to stay. They're going to the demand's going to increase. They're going to increase. The more dentistry you do, the waiting lists are going to be there. They're going to go up. So the concept of a managed waiting list, so your model of care will actually develop management of the waiting list. So a managed waiting list is a concept that I feel that needs to be incorporated in all future models of care. So whether the waiting list goes up, it doesn't matter. If you report to the minister or whoever and say, well, the waiting list has gone up, it doesn't matter, because your waiting list is actually managed by preventive maintenance programs, and you've got levels of disease stabilisation from various members of the team occurring for those people on the waiting list. So the waiting list is not a horrible name. An increase in waiting lists wouldn't be if you actually manage it correctly. So clearly the waiting times and preventive maintenance program intervals are more critical than actual waiting list numbers. Move on to the evidence. The common oral environment diseases are now considered chronic. We've mentioned that already. You know, dental caries and periodontal disease, they're really a chronic disease. They ebb and flow. They go through acute and chronic phases. You'll find that you know, dental caries can rear its ugly head, and number of end-stage lesions increase. And there are a lot of impacting factors: lifestyle, social, medical comorbidity. All those influence the acuteness or the chronic nature of chronic diseases. And you know, as we know, Edwina Kidd, you know, there was a, you know, counts way back that, you know, caries was a process culminating in lesions, and all we were doing in downstream was repairing those lesions with no management of the process whatsoever. So we're clearly on the same page. It's been talked about. We need to actually manage the process and have a model of care that actually manages that caries process, but also including those upstream issues, those upstream impacting issues. Most chronic disease, the dental caries and periodontal disease activity depends on the disease process. That just flows on from that. In the middle there, the chronic disease management requires a combination of individual, community and population approaches, and certainly with the social determinants of health. The individual, we're looking at downstream, we're looking at surgical intervention. We can also at the individual level have, within our model of care, have your preventive maintenance programs, and you've got your community programs, and certainly Sue's area, look at the community programs, and then you've got your population approaches, you know, your water fluoridation, you know, for example, the cigarette packets with anti-smoke, with pictures on it, etc., and key messages. Certainly in that area, that's a gap in the oral health area. I think that's an area yet to be explored, but they all play a role in a model of care. So for us here, on a day-to-day basis, it's principally the individual, and that's the downstream stuff, but it must include the preventive maintenance component and take into account the disease, the impacts of medical comorbidity and social comorbidity, and then also pathways as an individual into relevant community programs, and that can be either through medical GPs and other community organisations. And the population approaches are principally at higher level government levels, but certainly organisations such as DHSV can influence that as well. And I think that needs to be explored, certainly in the future, with the Commonwealth Government coming on board with moving towards a national public dental program. Okay. Sorry? Yep. I might just flick through then. The social and dental, as I've said, the social, dental, medical comorbidity effect and impact on dental disease process influencing care planning and priorities. The oral health improvement occurs synergistic with improvements in the social determinants of health and management of common risk disease. I mean, we can't get oral health improvement that occur independent of other areas. You can't have a population with high levels of diabetes 2 increasing and oral health, improving. I mean, you're not going to get an individual with a lot of other social impacts, social issues impacting on their daily life without, and then expect oral health as a siloed area to improve. So they have to work, they work in harmony with each other, the systems work in harmony, and you've seen that yourself. You don't have someone with, that's, an unmarried mother with 5 children, victim of domestic violence with pristine oral health. You very rarely see that. It's usually hand in hand with again, the mouth is a mirror of the body, and both medically and socially. I'll flick through. I mean, the preventive maintenance programs we looked at in Tasmania in the planning phase as intensive, moderate and review reinforcement, and they can move, patients can move between the intensive preventive maintenance program to the review and vice versa, and the influencing factor there are the impact, the medical comorbidity, the lifestyle and the social interaction. Say in Geelong at the moment, with the unemployment, those upstream issues, you'll find that general health and well-being starts to decline. You start to get increased unemployment, increased levels of stress, sort of smoking levels tend to creep up, diet deteriorates. There's a whole host of impacting issues, and therefore in that area over time you'll find that oral health starts to deteriorate. The primary healthcare team, jumped ahead there. The primary healthcare team, as I've mentioned, the oral medical allied health non-clinical approach is the effective way of managing a chronic disease, and that's what we're dealing with, so we need the full team. I'll flick through minimal intervention, dentistry, care phases. That concept needs to be embedded in any future model of care, and it certainly is. And the PMPs, whether it be intensive, moderate or review, is directed at home care. And by home care, I mean daily care. I don't care whether it's in the home. The home is the bigger picture, or the home of where someone, whether it's an institution, whether it's a residential care, wherever it is, a residential care facility, nursing home, etc. It is home care, and that's carried out by non-dental personnel. And that daily, that's the 99% of any model of care happens on a daily basis. 1% is that downstream stuff that we all do. Okay, I'll flick through. How many minutes we got here, Julie? 2. Okay, so health. Yeah. Okay, health. I did start late. Health literacy. I mean, clearly, as people have talked. I mean, Martin talked about health literacy. I think at the moment we've got a scale of 3, 41% nationally to maximise your model of care outcomes. But any model of care should be looking at increasing that. So your 60%, which is below 3. You've got to look at a model of care and the preventive maintenance program to actually raise that 60%, so increase that 41% up, or any model, or your cohort has to be raised to above 3. If less than 3, and that's, I mean, that case, the cases I was talking about, if you've got that sort of unmarried, 5 children, domestic violence, the literacy of that, health literacy of that individual would be quite low. And oral health's not a priority. There is too many impacting issues, so you can't expect the pristine mouth. And all you might want to do in a situation like that is that person, as in a preventive maintenance program is reinforcing, is getting some xylitol chewing gum being sent to that person, on a fortnightly basis. And these are programs that can be targeted and looked at, happening in Scotland at the moment, happening in Scandinavia. For instance, in Scotland, they have a program where the children that come along where parents can't afford to provide a lunch, they can provide a morning breakfast, evening meal. They don't come along when they have no lunch. Therefore, they provide them with food, and they target that group, and they provide that family with a toothbrush and fluoride toothpaste on a monthly basis, because they spend their money on on cigarettes, alcohol, gambling. So all these impacting issues, the family unit, very important. So these are all little models. These are models that we need to look at, and we certainly need to capitalise on in the future within public dentistry. Challenges I'll flick through quickly. Just a clinical scenario here. A couple of going right down to the grassroots level. So here a young girl, certainly very sick girl, hospitalisation, as you can see. Look at that swollen face, febrile, obviously required hospitalisation, high risk, high life-threatening situation, cavernous sign of thrombosis. That's just, so we know what to do. They've been hospitalised, expensive, but the impact, the social impacts, or the social background of that girl was significant. So you've got to work on that. Otherwise, the representation, you're not going to get the outcome you want at an individual level by just hospitalising, removing that, draining that tooth, putting on IV antibiotics and out. You need then that family, her family unit becomes a high-risk group, and your preventive maintenance program the family as the high-risk family, because those siblings and the parents are all high risk, and you aggressively manage that through a preventive maintenance program. That could be phone, it could be home visits, it could be a number of modalities you've got to use, and that's non-clinical personnel, that's with scripts, key health messages, but just reinforcement. And they may not want to respond to those messages straight off, so that's when you downgrade, but you still keep them in the loop, because oral health may not be a priority. There might be so many other impacting issues that oral health, by telling them how to brush their teeth and floss their teeth, is a waste of time. There are too many other issues. So this is a sick little girl with huge impacting issues from family, and that family is high risk and needs to be managed. And not just, this little girl, not just put on a recall list to come back in 3 months. You need to aggressively manage that unit if you want to capitalise on, from a population perspective. Okay, so we're looking at, here we are, the Tasmanian patient, again, look, not all Tasmanian patients have an OPG like this, but a lot do. So we have the advantage of being part of a health organisation. Obviously here, nothing to be saved, all teeth out, full clearance. So significant alcohol and drug issues, liver problems, major issues. We don't just silo it. They just say, just take the teeth out, let them go. In a health organisation, you refer off. Social work, you move on. Alcohol and drug services, counselling services. So that's that model of care, which then capitalises in the broader health sector. So that's not to say that that's going to happen everywhere. In Tasmania, that was easy because oral health's part of general health, part of the hospital system. I know it's separate here. So this teeth out, in some situations, teeth out, dentures in, forget about them. But significant other issues, significant psychiatric issues with this patient, suicidal. So you manage them, but you have a pathway from the dental straight through into that area to actually manage that quality of life. Very good population health outcomes, very good oral health into general health, but a structure to support it. Here we are, a young 20-year-old female, Tasmanian, very dry mouth. Again, I mean, this is the team approach. So this came in triage 2-6, can't see the 2-6. Urgent category pain 2-6, additional generalised caries, as you could see clearly. Primary care teeth management. So you're looking at medical, social, dental history. The oral health therapist does that. Radiographs taken by a Cert 4 DA or an OHT. Then you have a proposed plan, clinical pathways, team approach. You do a draft plan. The LA for the 2-6 is done by the OHT or a student, doesn't matter. You make a decision whether that tooth's going to be extracted straight off there and then, or whether you're going to do that the interim week. Quite often you'll take out the palatal 2-6 canal, pulp extirpation, put some odonto paste up and relieve the pain, and then make a decision later, put them on a stabilisation program. Seal and closure of that, if you did the seal and closure or obtained hemostasis by the OHT or students, whether they be a dentist or OHT student. So dentist in the next room, seeing the next patient. So it's a team approach. Very efficient, and it's the way you actually manage that intake area. General stabilisation, you look at the care plan, can be done by the oral health therapist, student or oral health therapist, or a dentist, doesn't matter, any member of the team. You utilise GICs, the resin modifiers, the silver fluorides, orthodontic bands, Kerasolve, ultrasodentine, all the minimal intervention type dental stabilisation techniques. And then they can be put onto a preventive maintenance program. You stabilise them, no definitive work done. You look at the social history, you might refer off to medical GP, you might look at social work, you might look at other programs, looking at what's happening in the house. That individual, that girl, was not interested in managing that. I mean, so you do definitive care on some of these anterior teeth, endodontics, resource intensive, they're going to fail. If you don't look at beyond, look back and look at the upstream issues, why is that mouth like that, and managing that, then all that money spent and time spent on restoring that mouth is just money down the drain. Okay, another case, again, you know, stabilisation. Stabilisation techniques, looking team, your DA, fluoride varnish, I know that's probably not happening here, it's not happening, it's happening up in the Northern Territory in their interventions, but certainly DAs need to play a role in fluoride varnish. That's the evidence base. Putting that on, whether it be paediatric area or whether it's in these situations, that needs, a DA needs to happen. Your initial home care done by DA, oral health therapist, toothbrush, dental cleaning, diet, xylitol gum, all that is a preventive maintenance program, but they may not respond to that. So they look at the response, so that response may drop down. So individuals may not respond to, as I've got the xylitol gum there, I'm very keen on xylitol gum or rinses, rinses aren't in Australia at the moment, but they are in the US. Chewing gum might be the first step, and that's all they do for 6 months. Then they start to, you know, use an interdental brush or flossing, but you don't saturate an individual which is saturated socially, impact, they're just not going to respond and not going to improve, nothing's going to improve, it's going to go in one ear and out the other. Referral to medical GP, relevant clinical pathways, appropriate waiting list, special referral if required, and then you reappoint for stabilisation, that's your managed waiting list. So you've got someone on a waiting list, but you report it as a stabilised waiting list. So that person's stabilised. It's not waiting for care, they're actually being cared in the appropriate manner. So a duty of care is being provided to all your individuals that you place on a waiting list. They're not just sitting there, tooth out, and sitting dumped there with a whole lot of open lesions and being left to flow off in the ether. They're actually being managed. Okay, the last thing is the paediatric GA. Clearly, you know, you want to, and that's been mentioned numerous times, a really key area that needs to be managed really well, and certainly the fruit's ripe for picking here, to reduce your readmission and also reduce your sibling admissions. Your family unit, as I talked about, in any GA wait list, your family unit is wait list, not just the individual. And then you aggressively preventive maintenance that family unit. You work on the family unit, not the individual. So usually the social, the upstream issues are impacting on the family, not just that individual. That individual is just one. So you might have a 6-month-old baby with no teeth at all, but the risk of that 6-month-old with no teeth ending up with a GA by the time they're 3 is really high if the 2 siblings before had the GA. So that becomes part of your model of care. Appropriate pharmacological products, male affected cases, I've talked about that. That's evidenced around in Scandinavia. Certainly if those cases that don't want to buy a toothbrush, toothpaste, they prefer to gamble, gambling issues, social issues, smoking, alcohol, you actually mail them the selected product, whether it be a toothpaste or toothbrush, interdental brushes, and you ring them and follow it up. Key messages, motivational interviewing, DA, OHT, and the post-op, obviously after a GA, is usually aggressive. High risk presentation of siblings, similar high risk as I mentioned. So here we have the, you know, GA waiting list, one little girl ready for GA. You'll see in the background, sibling. They're all part of the process. They're part of, you look at the high risk. One of them is going to GA, you look at the others to manage both their deciduous dentition, mixed and permanent dentition. To prevent this, you know, ending up another high cost, high resource intensive GA admission, which we've seen the levels that are occurring and the impact on the health dollar across Australia at the moment. So the way forward is plan. You've got a plan, you look at the development plan, look at your individual units, you've got a plan, you've got to look at your areas, units, facilities for possible trialling. You look at trialling it, just like in North Richmond. You've got 8 chairs in North Richmond, that's perfect. You don't need to do it in a whole 100-chair unit. It's good we're in Tasmania, we've got special care dental units within the hospital. That's the area where we're going to look at trialling the model of care facility. Very, very easy to do. and then you roll it out. And then you modify it for say, a community clinic, and it changes. You introduce a pilot, you may research it, and then you evaluate and review. Clearly, one size doesn't fit all, but basically the philosophy and principles do. One size won't fit all in models of care, but the principles of population health approach, preventive maintenance programs, looking at the upstream issues impacting on the downstream issues. It might be that you cherry pick and you end up with a model that suits your unit, your 2-chair, 8-chair emergency unit within the hospital, but won't suit something else. But the concept, the philosophy, whatever you do, if you take that next step from where we are now, then the realisation of the dollar, whether it be the Commonwealth dollar, whether it's the state dollar, from a population outcomes point of view, is realised. And you'll be part of a huge shift in oral health, moving towards a phase whereby you've got to actually make a difference to a population's quality of life and general health and well-being. Thanks, Julie.